Today we're talking about muscles, and we've got Professor Chinoy and colleagues who are going to be talking a bit about their extremely interesting viewpoint of myositis from a single center. They're going to introduce themselves and talk about the interests, and we'll see how we're going to go throughout the rest of this very nice podcast looking at the paper. And if you're interested, you'll have a click to download the paper and have a review of it accompanying this. We'll start off with Professor Chinoy. Hector, do you want to tell us a bit more about your paper?
Yes, thanks very much, Marwan. So the title of the paper is called Polymyositis, Is There Anything Left? A retrospective diagnostic review from a tertiary myositis center. So where this has come about is really us wanting to understand better what the term polymyositis actually means. And why is this important? Well, in clinical practice, patients want to know what condition they have, and it helps us and it helps them to decide what's going to happen about their condition in the future, the prognosis, and it also dictates what treatments we're likely to offer and how they're going to respond to these treatments. So having an accurate label is really important. Now, for years, we've used an old criteria from 1975, the Bowen and Peter criteria, to define disease. And this broadly divides patients up into poly and dermatomyositis. This was superseded in 2017 with publication of EULAR-ACR criteria, which used a points-based system to define polymyositis, dermatomyositis, and inclusion body myositis. Now, one of the criticisms leveled at this criteria was that whilst it did include antibodies for the first time, it only included Jo1 antibody as part of the classification. And we know that there's over 15 defined antibodies in myositis. And one of the other issues that we have is in clinical practice, we further subdivide patients with myositis into other conditions such as overlap disease, antisynthetase syndrome, immune-mediated necrotizing myopathy, and cancer-associated myositis. So there's a number of other classifications which are not accounted for with this other classification. Now, last year, we also published in the Rheumatology Journal looking at the performance of the EULAR-ACR criteria. And we studied 255 patients. Of those 255, 124 were classified according to the criteria as having polymyositis. But then when we delved further into it, only 37 of those patients had an expert assigned agreement that those patients actually had polymyositis. So Marwan, this brings us on to the context of this paper, is that we wanted to further characterize those 37 patients and actually asking the question of what is polymyositis and what does that terminology actually mean. So I'm going to pass on to Jesús to talk in more detail about this, who's the main author of the paper.
Okay, thank you. My name is Jesús Loarce. I'm from Madrid, from Ramón y Cajal University Hospital. And to discuss the study, this study was performed as a quality improvement project in the neuromuscular service at Salford Royal NHS in Manchester, and as a subsequent analysis of the work that was previously commented by Hector. So the objective of our current study was to undertake a detailed review on those 37 patients which were diagnosed with polymyositis, both by EULAR-ACR criteria and by expert opinion. These patients were carefully reviewed after nearly 1.5 years of follow-up from the previous work. We reviewed their clinical features, the complete myositis antibody profile using the European myositis line blot at Salford Royal NHS, and in some patients got additional testing for HMGCR antibodies by ELISA and immunoprecipitation. We also reviewed other relevant tests such as creatine kinase levels, EMG, muscle MRI, and of course muscle biopsy reports. So each case was discussed and was classified by consensus in one of the following subgroups that were polymyositis, dermatomyositis, inclusion body myositis, immune-mediated necrotizing myopathy, connective tissue disease overlap myositis, cancer-associated myositis, antisynthetase syndrome, and also non-inflammatory myopathy and specified myopathy. These cases were classified using our current knowledge of myositis subgroups, but also based on previously proposed criteria, including the ENMC criteria for inclusion body myositis and immune-mediated necrotizing myopathy, or the Trojanov proposed criteria for the connective tissue disease overlap myositis. And specified myopathy was used for those patients that had an inflammatory condition or myopathy that didn't fit in the previously stated subgroups. And finally, some patients were regarded as undetermined due to incomplete data if we didn't have enough data to allow for an accurate classification. Polymyositis was used for those patients that had a symmetrical muscle weakness without skin rash with respect to immunosuppressive therapy if they didn't fulfill for the other subgroup criteria. So after reviewing those 37 patients, only 9 remained classified as polymyositis. Regarding these 9 patients, none of them had a prior exposure for statins or for toxins. All of them had symmetrical muscle weakness with raised creatine kinase levels and evidence of muscle involvement with MRI or EMG. Of course, all of them were seronegative for all the myositis antibody panel. And in the biopsy reports, we found HLA1 upregulation, endomysial infiltrates in 4 patients, and perimysial infiltrates in 3. And we didn't find, of course, any other features such as protein aggregation, widespread necrosis, or perivascular involvement. These patients who had follow-up were confirmed to be responsive to immunosuppressive therapy. So with regards to other subgroups, 7 patients were classified as connective tissue disease overlap myositis, as they had overlap features such as Raynaud, interstitial lung disease, or arthritis, and other antibodies, including anti-PMSCL in 3 patients, anti-U1-RNP in 1 patient, anti-Q in 1 patient, and anti-Rho52 in other 2 patients. 5 patients were diagnosed with immune-mediated necrotizing myopathy regarding their biopsy results and positivity for either anti-HMGCR antibodies or anti-SRP antibodies. Interestingly, during follow-up, 2 patients were diagnosed as dermatomyositis, as they were found to be positive for anti-SAE1 antibodies, and even 1 of them developed rash during this follow-up. 3 patients were classified as cancer-associated myopathy, and we had 1 patient which developed an atypical muscle involvement and didn't respond to therapy, was biopsied and furtherly diagnosed with a myofibrillar myopathy. Within the unspecified group, which included 6 patients, we have 1 patient with HIV-associated myopathy. We had 1 patient with eosinophilic fasciitis-like syndrome. 1 patient was likely to be an inclusion body myositis, but he didn't fulfill the ENMC criteria. And we had 1 patient with an acute syndrome with proximal weakness and high CRP and ECR, but without evidence of muscle inflammation at the time he was evaluated at our center with normal creatine kinase and non-specific biopsy, which responded to corticosteroids, which is regarded as a probable polymyalgia rheumatica or a viral illness. Finally, 2 patients in this group were positive for anti-Rho52, but they only had symmetric muscle weakness. They didn't have any other features suggesting for an overlap myositis, and they didn't have any other antibodies. And the last 4 patients didn't have enough data to allow for a defined diagnosis. So maybe, James, now you want to comment on the results?
Yeah, thanks, Cesar. So really, I think this is really continuing the momentum since 1975 of the evolution in the classification criteria for idiopathic inflammatory myopathies. And really what's happened is dermatomyositis has remained as a fairly homogeneous group, but the other group, polymyositis, we've continuously chipped away at that really until there really is not much left. So of our original 255 patients, now we're only left with 9 who retain that classification of polymyositis. And that's essentially because we can't fit them into any of those other categories. So particularly immune-mediated necrotizing myopathy, CTD overlap myositis, and then inclusion body myositis. So in terms of implications for practice, I would really emphasize looking at patients with polymyositis or suspected polymyositis very carefully, particularly these seronegative patients, thinking carefully about whether they could have a condition mimicking an inflammatory myopathy, including muscular dystrophies. Think carefully about whether they could have inclusion body myositis, which we know doesn't respond to immunosuppression in the same way as the other inflammatory myopathies. And really, this does require quite close working between rheumatologists, neurologists, neurophysiologists, and also neuropathologists. So I think these are the important implications for practice. It does have an influence on treatment, so particularly making sure that we pick out those patients with non-immune myopathies or inclusion body myositis. And as Hector alluded to at the beginning, it has important implications for research, really, trying to understand what this remaining category is. So we've still got these 9 patients with polymyositis. Is this now the end game? Have we resolved all of the complexity within inflammatory myopathies, or in fact could with further work we subclassify these patients further and in the end get rid of polymyositis altogether? So I think that hopefully summarises, Marwan, the background to the study, the results, and where we think this fits into clinical practice.
That gives us quite a few answers, but just one last question. Do you think that the classification criteria are actually diagnostic? I mean, the Bowen criteria in 1975 were diagnostic, but are the current EULAR ACR are they classification criteria or are they diagnostic? Because you're applying the classification criteria in a diagnostic cohort of 55 and the subgroup of 37. But are you really saying that the ACR EULAR criteria should be taken as the clinical, Bible, if you like, and say, this is how I would want to diagnose my patients? Or do you just have to say your patient has got an inflammatory myopathy and is it autoimmune or it isn't? So just final comments from all 3 of you, if that's okay.
Should I start? So I think you're absolutely right, Marwan. The EULAR ACR criteria are not diagnostic criteria; they're classification criteria for use in research purposes. And in fact, what we've shown through this study and the previous study from our group is that if you apply the criteria without any kind of additional thought processes or criticism, you end up still with about half of the patients diagnosed with polymyositis. So I think what we've shown really is that from a research perspective, the ACR EULAR or the EULAR ACR criteria are helpful, but really further thought and careful work is required in clinical practice to diagnose these patients accurately. I don't know if Hector or Jesus want to add to that.
Yeah, so the criteria are really designed to ensure that we're enrolling the correct sorts of patients into research studies so that this can provide some reassurance, for example, as part of a clinical trial, that the correct sorts of patients have been recruited. It isn't a tool that should be used in clinical practice. Yet, at the same time, it was interesting to apply the criteria in our clinical cohort to see how the criteria actually performed. And I think one of the things that we've highlighted is indeed it should not be used in terms of diagnostic criteria. I think one of the things, just to add to what James was saying, and incidentally, that's James Lilleker, one of the co-authors on the study who was talking before. And it's also about the fact that one of the methods in which we used to define polymyositis was the immunoresponsiveness of the patients. And this also brings another question as to how do we define response to disease. But of those 9 patients, that we classified them as being immunoresponsive as well.
Okay. Well, that sounds pretty interesting. Jesus, do you have anything, any last words to say, or shall we just say that this has been a fairly good discussion about myositis, and I'm sure that we're going to hear a lot more about this cohort, and hopefully you'll be able to give us some pointers towards prognostic features, and maybe expand on the newly reported IVIG story and whether it's going to be replicated in your cohorts. So we look forward to hearing from you on these. Thank you very much.
Thank you, Marwan.
Thank you.